السلام عليكم ورحمة الله وبركاته. نرحب بالطلبة الأعزاء بمحاضرتهم اليوم اللي راح تتناول موضوعين، موضوع DVT and Pulmonary Embolism، والموضوع الثاني هو Peripheral Vascular Disease. بالنسبة للموضوع موضوع ال DVT Pulmonary Embolism هو يعتبر صراحة واحد من المواضيع المهمة جدا، لأنها صراحة increasingly recognized and increasingly detected and recorded with the availability of the precise imaging techniques اللي هو high resolution pulmonary CT angio. المحاضرة راح تتناول الفقرات التالية، هي ال clinical importance of the disease، بعض ال basic physiological concepts related to the subject، شنو الديفينيشن مال DVT pulmonary embolism، شنو ال predisposing factors، how do they present, and what are the investigative tools to prove the disease. استكمالا لموضوع the clinical importance of the DVT pulmonary embolism. طبعا نقدر نطلق على ال DVT pulmonary embolism really a public health problem. لا تخلو ردهات الباطنية، ردهات النسائية، ردهات الكسور، ردهات الأورام، سواء solid malignancy أو الهيماتولوجيكال malignancy، من good number of cases with DVT pulmonary embolism. ولذا لا تكاد تخلو ردها من الردهات أو ردها من ردهات العناية الفائقة والإنعاش من وجود حالة أو حالتين من ال DVT pulmonary embolism. نعم، ولذلك يعتبر من المواضيع المهمة جدا اللي تحتاج keeping high index of suspicion in order not to miss the diagnosis of this disease. We will start speaking about some basic concepts نشوفها relevant to the topic حتى نقدر نستوعب ال therapeutic options اللي هي مرتبطة بهذا الديزيز. شغلتين لازم نعرفها هي أولا منظومة ال coagulation والانتي coagulation الموجودة بجسم الإنسان، وثاني شيء لازم نعرف بعض الحقائق عن البلمونري سيركوليشن حتى نعرف احنا السيكولي اللي ممكن تنتج بسبب البلمونري امبوليزم. هذا السلايد هو صراحة يراوينا how critically important the delicate balance between natural antithrombotic mechanisms that are present in the body in response to thrombotic insult. طبعا النتيجة النهائية هي أن تكون توازن دقيق جدا بين الانتي ثرومبوتيك والثرومبوتيك stimulant in order to maintain the blood fluidity constant and at the same time harbors effective hemostatic mechanisms to prevent bleeding. طبعا احنا حتى يعني نفهم this critical balance between thrombotic and antithrombotic mechanisms، لازم نعرف انه بعض الحقائق عن شيء مهم اللي هو اسمه endothelial system اللي هو single layer epithelium endothelium lining the vascular system. It's really a system rather than rather than merely cells only. It's a system that exerts multiple functions. One of these functions here, the antithrombotic properties. These antithrombotic properties, when are lost, or when this endothelium is injured, the thrombogenic constituents of the subendothelial vessel wall will become exposed to the circulating blood. So we have to know that we've got we need to have a normally functioning endothelial lining of the vascular system. The process of coagulation, when there is a breaking, when there is breaches or breaking in the function or in the anatomical integrity of the endothelial system, we will have the following phases of response. اللي هي عندنا we've got the vascular phase in form of vascular spasm. We've got the platelet phase اللي هي involves two phases: platelet adhesion, that was followed by platelet aggregation, and then the clotting or coagulation phase, which involves the activation of the coagulation factors both via intrinsic and extrinsic pathway, with which ultimately lead to formation of mature thrombus. So, starting with the vascular phase. Vascular phase mainly relies on the process of vascular spasm. Vascular spasm will reduce the blood flow to the area, reducing the speed of flow, and will lead to stagnation, and finally precipitate the process of hemostasis or thrombosis. The second phase of process of thrombosis or thrombogenicity is the platelet activation. It happens usually at the site of injury, vascular injury, either functional injury to the endothelial wall or anatomical injury and de-endothelialization. Platelet will adhere to the exposed subendothelial surface via with the mediation of von Willebrand factor that attaches to the platelet glycoprotein 1b receptor, and this will lead to sticking of the circulating platelets to the damaged vessels. The adherent platelet will undergo what we call it the release reaction, which lead to augmentation and recruitment of new platelets to that site, together with the exposure of the or expression of the glycoprotein 2b3a receptors, which are important mediators of platelet aggregability. The fibrinogen that is formed by the third phase, which is the clotting phase, will further cross-link the platelets together with the mediation of these important glycoprotein 2b3a receptors. The third phase the third phase of coagulation or thrombosis is the formation of a clot via activation of the coagulation factors or clotting factors. The clotting factors will be activated بطريقتين. طريقة الاكسترنسيك باثوي اللي هو يحتاج إلى tissue factor يعني exposure of tissue factor will exposure of the clotting system to the tissue factor, and this tissue factor will lead to formation of conversion of factor 7 into factor 7 active, and this factor 7 tissue factor complex will activate factor 10 into factor 10 active, which we call it the common pathway. Factor 10 active will activate the thrombin, the prothrombin into thrombin, and the thrombin will activate fibrinogene into fibrin monomer that will polymerize with the and and form cross-link fibrin with the assistance of active factor 13. While the intrinsic pathway usually it does not require the tissue factor, and we call it the intrinsic pathway. It starts with the activation of factor 12 via assistance of pre-kallikrein and high molecular weight kininogene, and this will activate factor 11 that will activate factor 9, and factor 9 will activate factor 10, and factor 10 will follow the same course that we speak about in the extrinsic pathway. So the common pathway starts from the activation of factor 10. Factor 10 will activate prothrombin into thrombin. Thrombin will activate fibrinogene into fibrin. The extrinsic pathway involves factor 7 and the tissue factor, while the intrinsic pathway involves the activation of factor 12, 11, 9, then activation of factor 10. Now we will have an idea about what we have to counterbalance this thrombotic tendency of the blood. We've got what we call it the natural antithrombotic mechanisms that are present in the human body, which includes the antithrombin 3, protein C and the protein S, tissue factor pathway inhibitor, and the natural fibrinolytic system. These four group of proteins and enzymes will be activated in a complex way in order to balance and refine the process of thrombosis and make it very limited to the site of injury, and not to overwhelm the circulatory response. And keep in mind, these are called the natural antithrombotic mechanisms, involving the antithrombin 3, protein C, protein S, tissue factor pathway inhibitor, and the fibrinolytic system. الآن بعد أن عرفنا أنه عندنا خواص نسميها thrombotic properties in the blood، عندنا antithrombotic properties، وهذني البروتينز أو الانزيمز بيناتهم في حالة توازن حتى البلد يمشي بفلويدتي معينة كافية to maintain the circulation. هنا احنا من نبدي نحتاج treatments. لازم هاي الخلفية اللي أخذناها قبل شوية راح تفيدنا كلش بالتعرف على الجروبس of drugs اللي نستخدمها in order to increase fluidity of the circulating blood, which we call it the anticoagulants. أول جروب من الانتيكواجولانتس هي اللي هي chemicals that antagonizes the vitamin K. vitamin K هو cofactor مهم بالcarboxylation process of factor 10, factor 9, factor 7, factor 2. اختصارا نعرفه 1972. One of the famous drugs that antagonizes vitamin K هو الوارفرين. عندنا الجروب الثاني من الانتي كواجوليشن هو what we call it the unfractionated heparin. unfractionated heparin هو big mother molecule يحتاج إلى antithrombin 3 أو يرتبط بالأنتي ثرومبين 3 ويسوي له اكتيفيشن. والأنتي ثرومبين 3 هو يعمل على تعطيل عمل فاكتور 12 فاكتور 10 فاكتور 9 and فاكتور 2. low molecular weight heparins هي عبارة عن synthetic materials that contains the active parts of the mother molecule heparin and acts with special pharmacological properties different from the mother molecule unfractionated heparin. So طبعا احنا عندنا بعض الفارماكولوجيكال differences بين الهيبارين والهيبارين unfractionated heparin والlow molecular weight heparins. هذا المكان مو موضوع تداولها. ايضا بالنهايه هي راح الانوكسابارين او اللو molecular weight heparins راح تنتهي بالدي اكتيفيشن of factor 12 factor 10 factor 9 and factor 2. the other anticoagulants هي نسميها النوفل anticoagulants اللي هي involve the direct thrombin inhibitor اللي هو ما يحتاج inhibitor للثرومبين انزيم بدون الحاجة إلى الانتي ثرومبين 3 اللي هو الدابيجاتران وإلى الفاكتور 10 active inhibitors اللي هي الابيكسابان والريفاروكسابان. هذين نسميهم الدايركت ثرومبين inhibitors والفاكتور 10 active inhibitors. هذين نسميهم novel anticoagulants. هذين last anticoagulants last two groups of anticoagulants يعتبرن فد خطوة مهمة وجديدة بال أضافت لنا كثير من السهولة والخواص المفيدة للأنتي كواجولانت بطريقة أحسن من الأولدر وان اللي هو الفيتامين كي ديبندنت أنتي كواجولانت اللي هو الوارفرين. نعم. بهذا السلايد راح ناخذ فكرة بسيطة ومهمة في نفس الوقت عن البلمونري سيركوليشن. احنا عندنا بعض الفروق اللي تفرق البلمونري artery from a systemic artery. البلمونري arteries هي عبارة عن thin wall arteries تحتوي على endothelium tunica intima tunica media. tunica media مالتها تختلف عن systemic arteries بوجود thin layer of smooth muscle cells. thin layers of thin tunica media with thin layer of smooth muscle cells that is followed by the adventitia. وبالنتيجة من ذلك راح يكون البلمونري circulation هي incapacitance vessels يعني بها مرونة عالية استيعابية تستوعب blood flow بدون أن توجه له مقاومة ملحوظة. ولذلك بالرغم من كون البلمونري فلو هو مشابه للسيستميك فلو من هالناحية لكن البلمونري بريشر هو لا يزيد في معظم الحالات عن 1/3 of the systemic pressure. وكذلك البلمونري vascular resistance هي لا تزيد في الحالات الاعتيادية عما يقارب 1/10 of the systemic vascular resistance. لكن في حالات معينة من مثلا exposure of the pulmonary circulation to long-standing high pressure مثلا يكون عندنا مثلا في large VSD أو chronically elevated pressure. This pulmonary circulation, these pulmonary arteries that has low resistance, that has thin tunica media with limited quantity of smooth muscle cells and fibrous tissue will be remodeled يعني يصير بها تغيرات anatomical changes that will convert it into that will convert it into different vascular system. وبالنتيجة مع مرور الوقت راح تبدي تتشابه من ناحية تشريحية مع systemic arteries with thick tunica media وهذا يؤدينا إلى pulmonary hypertension، زيادة pulmonary vascular resistance وزيادة pulmonary vascular pressure، وبالنتيجة will lead to irreversible pulmonary hypertension and subsequent right ventricular failure. هذا اللي يصير عندنا مثلا بالشنت procedures بالشنت باثولوجيز مثل ventricular septal defect، مثل patent ductus arteriosus، هذا بالcongenital heart disease. أو يصير عندنا بالموضوع المحاضرة مالتنا هو الpulmonary embolism. من يصير عندنا pulmonary embolism واحدة من major pulmonary arteries، هذا البريشر اللي كان يتسرب من هاي المنطقة اللي بيها خثرة راح ينتقل إلى السيركولاتري بارتس اللي ما بيها بريشر، اللي ما بيها كلوتس. وهذا الاكسبوجر الى بريشر اضافي وفلو اضافي مع الزمن will lead to systematization of these arteries with subsequent remodeling and changing of these arteries into histologically similar to simulate the histology of systemic artery with irreversible development of pulmonary hypertension. فكرة ثانية لازم نفهمها انه احنا عندنا في كل segment من اللنج اكو عندنا arteries branches of the pulmonary arteries. في العادة احنا عندنا ventilation من الاريا اللي بيها ventilation، عندنا بيها there is good perfusion to these areas. عندنا matching، يعني اكو تناسق وتشابه بين المناطق اللي بيها good oxygenation good aeration وهي مناطق اللي بيها good perfusion. في حالة حدوث خلل بالventilation في مكان ما، the perfusion to this area will be diverted into other area that is well aerated in order to compensate for this lost less aerated or diseased lung parenchyma in order to get benefit from the maximum benefit from the oxygen exchange in the well aerated areas. هذا السلايد يوضح لنا فكرة ال ventilation perfusion matching. احنا عندنا لنج وقصبة هوائية ويدخل بها الهواء. احنا شنو نستفاد اذا كان عندنا لنج يدخل بها هواء واكسجين لكن ما عندنا circulation تودينا blood حتى يصير بي oxygenation ويرجع لنا ينقل لنا الاكسجين الى سيستميك. لذلك لازم كل لوبس او كل سيجمنت يدخل لها بلد كافي حتى يصير عندنا adequate oxygenation of the blood. في الحالات الطبيعية اكو عندنا ventilation perfusion matching، يعني كل سيجمنت من اللنج اكو لها فلو مناسب يتناسب ويا الفنتيليشن. في حالات معينه مثل البلمونري امبوليزم ايش راح يصير عندنا؟ فنتيليشن perfusion mismatch، يصير عندنا مناطق بها فنتيليشن ومناطق اخرى مناطق بها فنتيليشن لكن ما بها perfusion. العكس يصير في حالات اللنج ديزيز chronic obstructive lung disease مثلا او lung fibrosis، راح يصير عندنا مناطق بها perfusion لكن ما بها ventilation. هذا نسميه ventilation perfusion mismatch. اللي يصير عندنا بالpulmonary embolism ventilation perfusion mismatch اللي هو ناتج عن obstruction of one of the pulmonary arteries supplying an area with normal ventilation. Now moving to the precipitating factors of the DVT pulmonary embolism. Precipitating factors حتى واحد ما ينسى دائما يتذكر هذا المثلث اللي هو الفيرتشوز ترايد. Virchow's triad اللي هو عندنا موضوع له علاقة بالفلو. كل ما يكون الفلو slow كل ما possibility of thrombosis تكون عالية. Coagulability of the blood itself مثل المرضى اللي عندهم thrombocytosis، مرضى عندهم erythrocytosis، أو عندهم hypercoagulable states أو deficiency of the natural anticoagulation. هذني نسميها hypercoagulability state أو endothelial injury. endothelial injury كان تكون inflammatory process، mechanical injury. تمام. these factors may be present all together in the same patient, or we've got one of them. And any one of them, when it's present, any one or two or three of these factors will render the patient susceptible for the development of DVT pulmonary embolism. So this table shows different types of predisposing factors that may cause or precipitate development of DVT pulmonary embolism. These include surgeries, whether obstetric or general surgery, the cardiorespiratory diseases like COPD, congestive heart failure, the fractures, varicose veins, malignancies, increasing age, previous proven DVT pulmonary embolism. All these are factors that operates in a way or another in one or more of the limbs of the Virchow's triad. So, after a patient who got one of the predisposing factors develops DVT pulmonary embolism, what are the clinical features of DVT pulmonary embolism? We've got طبعا احنا ممكن يصير عندنا DVT alone, DVT with pulmonary embolism, or pulmonary embolism alone without evident DVT. شنو هي الكلينيكال فيتشرز اللي هي DVT؟ هي بسيطة، عبارة عن leg pain and tenderness and swelling. ممكن نلقى palpable cord-like red discoloration of the veins of the legs, commonly the legs, not necessarily the legs. ممكن تكون upper limbs also. Also dilatation of the superficial veins. طبعا لازم نخلي بالنا انه 30% من الكيسز of only 30% من الكيسز of pulmonary embolism DVT is confirmed. يعني 30% إلى 40% من pulmonary embolism نقدر نلقى DVT. Otherwise احنا ما نلقى DVT. Moreover ممكن يكون مريض عنده minor DVT with prominent symptoms or major DVT without prominent symptoms. خلي بالنا دائما الديفرنشال diagnosis مال DVT هو ruptured Baker cyst. مثل ما قلنا احنا ممكن يكون عندنا DVT alone without pulmonary embolism ونلقى بس clinical features مال DVT، أو نلقى pulmonary embolism alone without features of DVT، وممكن نلقى both DVT and pulmonary embolism, both features present in the same patient. Presentation of DVT of pulmonary embolism depends on the size of the embolus. It could be small one, medium one, or big one. The small one might be asymptomatic or causing minor shortness of breath and chest discomfort, while medium-sized one might cause shortness of breath, dyspnea, tachypnea, hemoptysis, pleuritic chest pain on the pleural rub, while massive one may present with sudden death or shock or severe central chest pain, cyanosis, probably acute right ventricular failure with elevated JVP and loud splitted pulmonary component. هذا السلايد يلخص varieties or modes of clinical presentation and variable findings that could be found on the investigations. تمام. ككلينيشن في نهاية المطاف لازم من يصير عندك أي نوع من البرزنتيشن لازم تخلي بالك أكو فد شيء اسمه differential diagnosis. احنا مو دائما البرزنتيشن هي clear cut. We should keep in mind other possibilities that more or less having some sharing features with the pulmonary embolism. هي acute myocardial infarction, acute aortic dissection, pneumonia, pneumothorax, and musculoskeletal chest pain. طبعا احنا من يوصل المريض ناخذ منه history, physical examination, شنو predisposing factor، ويصير عندنا احتمالية أن يكون عندنا واحد من الاحتمالات اللي واردة بهذا المريض أن يكون عنده DVT أو pulmonary embolism. شنو الأشياء اللي نسويها generally الأشياء اللي نسويها to prove or to support our potentially or suspected diagnosis of pulmonary embolism هو chest X-ray, ECG, arterial blood gas analysis, D-dimer, CTPA, Doppler ultrasound, echocardiography, and finally pulmonary angio. أولا بالنسبة للchest X-ray طبعا واحدة من أهم الأشياء اللي لازم نعرفها بالنسبة للchest X-ray finding بالpulmonary embolism هي أنه most of the time it comes normal. However, it helps to exclude other differential diagnoses. But sometimes it can harbor some features that suggest diagnosis of pulmonary embolism. شنو الأشياء اللي ممكن نشوفها بالpulmonary embolism؟ ممكن نشوف oligemia in a lung field، ممكن نشوف large pulmonary conus or pulmonary artery, elevated hemidiaphragm related to collapse, pleural effusion on same side related to irritation and inflammatory response, horizontal linear opacities bilateral usually in the lower zones, and wedge shape opacities related to pulmonary infarction, and pulmonary opacities in the lung parenchyma. And these are طبعا many of them are non-specific features, but it can help when compared with the clinical context. هذه واحدة من الأمثلة من الإكس-راي signs of pulmonary embolism. بهذا المكان right upper lobe راح نشوف some form of oligemia compared with the same area on the left lung field. وهنا نشوف الهامبتونز hump اللي هي peripheral pleural based wedge shape infiltration that occasionally seen in pulmonary embolism. The second investigative tool helps us to prove or support the diagnosis of suspected pulmonary embolism هو the ECG. Usually we can have many ECG features seen in pulmonary embolism. However, these features are not specific for pulmonary embolism. These include sinus tachycardia, right axis deviation, right bundle branch block, RV strain, ST depression T inversion from V1 to V4, and what we call it S1 T3 Q3, or the acute core pulmonary, which is seen in less than 10% of cases of pulmonary embolism, seen as an S1, lead 1, T3, and Q3. So these are features that may be of help in improving diagnosis of suspected pulmonary embolism. The third investigation that would help to evaluate and assess patients with suspected pulmonary embolism is the ABG. Classically, we usually find hypoxia and hypocapnia related to hyperventilation and subsequently lead to respiratory alkalosis. The fourth workup tool is the performance or detection of the D-dimer, which is a plasma protein specifically produced after lysis of a cross-linked fibrin by the natural anticoagulant system, plasmin. Levels are almost invariably elevated in the presence of acute venous thromboembolism. So measurement of D-dimer level is a sensitive test for recent DVT and pulmonary embolism. However, numerous non-thrombotic conditions including sepsis, pregnancy, surgery, and cardiac and renal failure can also cause elevated levels. So the role of D-dimer is limited in helping for exclusion of pulmonary embolism for those with low probability rather than proving for patients with high probability for pulmonary embolism. إذن الدي-dimer ممكن يطلع عندنا بعديد من الكونديشن، فهو مو specific أي process of thrombosis including the cannula. So بس هو يفيدنا بشيء واحد، انه عندنا suspicion of pulmonary embolism, and this suspicion bears low probability of the case for being pulmonary embolism. Then if the dimer test comes negative, then it helps us to exclude the diagnosis of pulmonary embolism. Moving to the gold standard tool to diagnose pulmonary embolism with accuracy of nearly 98%, which is high resolution CT pulmonary angio. You can see these clots filling the area of the bifurcation. We call it saddle-shaped thrombus, and almost obstructing both right and left main pulmonary arteries. Echocardiography and Doppler ultrasound are very valuable tools that help us to evaluate patients with suspected pulmonary embolism DVT. Echocardiography can show right side dilatation, can show right side failure or hypokinesia. It can show the clots itself falling in the inferior vena cava or the right atrium, right ventricle, or the major pulmonary arteries. And also you can then invasively measure the pulmonary circulatory pressure. Also, the Doppler ultrasonography helps us to diagnose the presence of DVT and the extent of thrombosis in the venous circulation. Ventilation perfusion scan مثل ما حكينا قبل قليل، هذا يعتمد على مبدأ انه نعطي سكان فور فنتيليشن وسكان ايزوتوب سكان فور perfusion، بعدين نسوي ماتشنج. هذا الفحص بخاصية مهمة، انه dose of radiation exposure is very limited compared to CT. نستخدم عادة بالpregnant ladies اللي عندنا strong suspicion of pulmonary embolism، بس ما نقدر نسوي CT because of radiation hazard. وبنفس الوقت ما عندنا other than invasive evidence that helps us to prove the diagnosis of pulmonary embolism. إذن فائدته الأساسية هو بالpregnant ladies. Pulmonary angio طبعا تقريبا no more used nowadays for the diagnosis، لأنه حلت كثير من الوسائل اللي هي أقل invasive وأكثر دقة من البلمونري انجيو. البلمونري انجيو هو old tool بدقة عالية، لكن هو يعتبر invasive and يعني rarely performed nowadays for the diagnosis of pulmonary embolism. لكن ممكن احنا نستخدم pulmonary angio for the diagnosis of pulmonary hypertension that is being developed secondary to chronic thromboembolic disease. هذا الالجوريثم. طبعا المرحلة الثانية احنا يعني صعب نسوي implication لهذا الدايجرام، لكن لا بأس بالاطلاع على how clinically we work in order to prove or confirm the diagnosis of pulmonary embolism. تمام. بالنسبة للتريتمنت of pulmonary embolism, we've got both treatment of acute pulmonary or pulmonary embolism DVT and prophylaxis. بالنسبة للprevention هي prophylaxis or prevention. Prophylaxis is the single most important measure for ensuring patient safety in hospitalized patient. تشمل أشياء كثيرة بالمرضى والعمليات الجراحية اللي بها خطورة عالية إنه المريض يكون DVT، هو إنه نستخدم compressive stockings، نستخدم prophylactic anticoagulation، نستخدم measures of early mobility and calf massage and management of risk factors, trying to correct them in order to limit their implication in causing DVT pulmonary embolism. This slide explains how does the compressive stockings helps in preventing DVT. The major treatment options available for DVT pulmonary embolism is the use of anticoagulation, and we've got different classes of anticoagulation we speak about in the previous slides. Generally, the duration of anticoagulation depends on the presence or absence of provoking factor. 3 months for the provoked DVT without pulmonary embolism, 6 to 12 months for unprovoked DVT or those with pulmonary embolism. يعني المريض اللي عنده DVT provoked like by fracture or immobility, then we can for a reason or another we can continue only for 3 months, while those without provoking factor or those with pulmonary embolism DVT that was complicated by pulmonary embolism, the duration of treatment of 6 to 12 months, and for those without a provoking factor or with recurrent DVT pulmonary embolism, then we label them as thrombophilic cases, and we continue anticoagulation for the whole life, i.e. lifelong anticoagulation. Fibrinolytic therapy will be used for massive or submassive pulmonary embolism. Finally, we have to keep in mind that emboli could be things other than clots, including air embolism, fat embolism, tumor embolization, septic emboli, and amniotic fluid emboli. السلام عليكم. إن شاء الله نبدأ بالقسم الثاني من محاضرتنا اللي هي راح تكون مخصصة للperipheral arterial disease. في البداية لازم ناخذ تعريف بسيط على الperipheral arterial disease. peripheral مثل ما عندنا شيء اسمه central nervous system, peripheral nervous system. عندنا بالارتريز what we call it the peripheral arterial disease. كأنه coronary artery disease تعتبر كأنه central nervous system. peripheral arterial disease هي diseases that affect arterial territories other than coronary arteries, like lower extremity, carotid, renal, mesenteric, etc. The most common etiology of the peripheral arterial disease is atherosclerosis, but also it results from thrombosis, from other etiologies, inflammatory conditions like vasculitis and embolism. the term peripheral arterial means diseases of the arteries other than coronary, while peripheral vascular disease includes veins and lymphatics, diseases that affects venous system and lymphatic vessels. The epidemiology of peripheral arterial disease is affecting approximately 3 to 4% of the studied population based on ABI. ABI is the abbreviation of what we call it ankle brachial index. We will speak about this tool, investigative tools, in the next slides. It affects males more than females. Usually 1/3 only of the cases are symptomatic, the other 2/3 are asymptomatic. The risk factors for development of peripheral arterial disease, as you can as we said, that the most common etiology is atherosclerotic process, and therefore it shares common risk factors for atherosclerosis, risk factors for atherosclerosis in the coronary artery disease, like age, diabetes, dyslipidemia, smoking, hypertension, hyperhomocysteemia, obesity, elevated C-reactive protein, and chronic kidney disease. However, the weight or the impact of certain risk factor is different from coronary territory, and being having a strong impact of specifically diabetes and smoking as more potent risk factors in contribution to the development of peripheral arterial disease, in a way not that seen in the not in the same way that seen in patients with coronary artery disease. اللي نقصده بهذا الكلام انه قوة التأثير risk factor هو صحيح موجود نفسه بالperipheral arterial disease وموجود بالperipheral vascular disease، بس قوته بالperipheral vascular disease هي ما تشبه قوته contribution to the coronary artery disease. السموكينج والدايابيتس لهم قوة أكثر بالمشاركة أو تسبيب peripheral arterial disease، ما تشابه قوتهم بتسبيب الكوروناري artery disease. بالنسبة لل risk factors، اكو فشي لازم نعرفه انه risk factors contribution in development of peripheral vascular disease هي acts in a synergistic way, i.e. not in a summative way. It acts in a synergistic way, in a way that when a patient with say diabetes has 2 to 3 folds risk of peripheral arterial disease, and when the patient has another risk factor like smoking, the risk which alone contributes to 2 to 3 fold also raise, the summative or the synergistic overall risk will not be just the summation of 3 plus 3 will be 6. It will be more than that because of synergistic interaction between these two risk factors. هنا حبينا ننوه على واحدة من الحقائق المهمة، انه atherosclerotic is an inflammatory process, and inflammatory markers like C-reactive protein, leukocyte adhesion molecule, interleukins correlate with the development and extent and activity of atherosclerotic peripheral arterial disease. بهذا السلايد راح نستعرض بتعداد الأشياء الأساسية اللي نستخدمها أو الانفستيجاتيف تولز الأساسية اللي نستخدمها in the diagnosis and detection of the extent of the atherosclerotic peripheral arterial disease, and we will pass over them one by one in the next slides. أول فحص نبدأ به، وهو فحص مهم وسمبل ونون انفيزيف، هو what we call it ankle brachial pressure index. الانكل brachial pressure index هو عبارة عن مثل ما تشوفون هنا، عبارة عن detection of the blood pressure in the arm, systolic pressure in the arm, and systolic pressure in the foot by using what we call a Doppler stethoscope. Simple handheld Doppler stethoscope. Division of the ankle systolic pressure over the highest ankle pressure over the highest arm pressure will be recorded as an ankle brachial pressure index. If these figures, the figures on the right upper border of the slide, showing the normal values for the for this measurements. If the ratio is more than 1.3, it means that these arteries are heavily calcified, stiffened, and non-compressible. Normal ratio 1 to 1.3. If it is below 0.9, it indicates mild to moderate peripheral arterial disease. If it is below 0.4, it indicates severe peripheral arterial disease. The toe brachial pressure index نستخدمها بالcases. نستخدم special detecting probe when there is cases of non-compressible pedal pulses. The toe brachial pressure index less than 0.7 are usually considered diagnostic for lower extremity peripheral arterial disease. The other non-invasive test used for detection and description of peripheral arterial disease is the ultrasound, the Doppler ultrasound. As you can see that we've got what we call a Doppler signal, which is in the lower part of the image, which reflects the floor and depends on the Doppler phenomena. When the Doppler signal reconstructed into 2D image, we call it duplex ultrasound. And when color signals impregnated into this image, we call it a triplex ultrasound. It's a very useful tool, it's commonly used, and is very valuable in detecting and description of peripheral arterial disease, and it's widely available. The MRI and its brother, the CT angiography, MRI angiography and CT angiography, are also valuable tools and are indispensable tools in certain territories where they are not accessible by the Doppler ultrasound. They are specifically useful for aneurysms and intracranial vessels. The cardiac MRI and the magnetic resonance angiography and the CT angiography are capable of 3D reconstruction of the images and bone subtraction. They are very helpful in 3D imaging and very helpful in certain procedures used to treat peripheral atherosclerotic peripheral arterial disease. And also they are increasingly available for clinical use. The final test, which is really not a test only, it's a therapeutic facility, is the contrast angiography. It involves cannulation, selective cannulation of the one or more of arterial territories, and injection of iodinated contrast material, and directly visualize the vascular tree. Meanwhile, you can at the same time introduce certain tools like balloons and stents used to treat obstructions, or push coils or embolization material to treat vascular anomalies. It's also widely available tools, but it is invasive and harbors the risk of contrast-induced nephropathy. What are the modes of presentation of patients with atherosclerotic peripheral arterial disease? There is a range or spectrum of clinical presentations of patients with peripheral vascular disease, ranging from asymptomatic, accidentally discovered, to intermittent claudication. Then, when it progressed to critical ischemia, where the limb is threatened to be to have tissue damage, and then the last one, which is the acutely ischemic limb. Intermittent claudication. The first mode of presentation is intermittent claudication, which involves a sense of fatigue, discomfort that affect muscle group related to the arterial territory affected. The pain is usually relieved within 10 minutes of rest, and also relieved by attending dependent position. The location of symptoms are often related to the site of arterial stenosis, like calf claudication, thigh claudication, buttocks or arm or jaw claudication. The claudication distance is reflective of the severity of stenosis. This slide shows the importance of different parameters contributing to or different factors contributing to production of symptoms. This equation, the Q means the flow, change in the delta P means pressure, multiplied by the radius, which is the diameter of the vessels, divided by 8 viscosity, by the viscosity of the blood, and the multiplied by the length of the lesion. So any long lesion is more likely to cause symptoms. Any increase in the viscosity of the blood will produce more symptoms. Any reduction in the radius of the vessel will be reflected as a reduction in the flow, and hence in the causation of the symptoms. It is important to recognize that symptomatology depends on the supply, the balance between supply and demand. Sometimes we've got increasing demand, and will produce ischemia despite normal blood flow. Or on the other hand, we've got normal demand but with the reduction of the flow. It is important to differentiate intermittent claudication from lumbosacral radiculopathy, from arthritis, from primary muscle disease, and from venous claudication produced by chronic venous insufficiency. This table would show you some hints that helps to differentiate intermittent claudication from lumbosacral or spinal canal stenosis. What about the physical findings in patients with peripheral intermittent claudication? Actually, major findings is in the arterial examination, arterial system examination, in which we could find absent or weak pulses in the affected anatomical sites. We could find bruit related to the presence of stenosis. The skin overlying the affected organ will be pale, sometimes red or blue, depending on the extent of ischemia. The distal extremity changes in its color depending on the position of the leg. When the leg is dependent, it will tend to be red. When the leg is elevated, the for more than 1 minute, the limb tend to be pale. There is decrease in the skin temperature. Capillary refilling time will exceed the normal. The skin is usually dry, scaly, atrophic, and usually hairless. The nails will be brittle and dystrophic, and sometimes at the term or the final stages of extensive or severe ischemia, there will be non-healing ulcers and wounds, and ultimately finger loss or forefoot amputation. This slide shows how to perform capillary refill time. The capillary refill time is prolonged when it exceeds 2 seconds. A prolonged capillary refill time suggests diminished localized blood flow related to ischemia, shock, or dehydration. It's not merely related to ischemia or reduction in the blood or occlusive disease. It also can be produced by shock or dehydration or any circulatory collapse. These slides are showing different findings related to arterial or patient with peripheral arterial insufficiency. You can see that the skin is hairless, the nails are dry, brittle in the first slide. Here there is color changes, and you can see that the left lower limb is muscle is atrophied. These are the third slide is showing gangrenous changes, and here you can see that the nails are dystrophic and always lost with the blisters on the fingers. Here you can see a demarcation line, and this is the arterial non-healing vascular ulcer. This slide shows clinical categorization of patient with peripheral arterial disease. We've got two systems, the Fontaine classification system and the Rutherford classification system, in order to grade the clinical the clinical severity of patient with intermittent claudication or peripheral arterial insufficiency, in a way similar to NEHA functional classification or angina classification, Canadian angina classification for stable angina, or American Heart Association classification NEHA for the grading the severity of symptoms of heart failure. Here we've got the Fontaine classification and the Rutherford classification that grades the clinical severity of peripheral arterial disease. Now, how do we treat patients with peripheral arterial disease? It relies on two principles. First principle is to reduce the cardiovascular morbidity and mortality, and the second is improvement of the quality of life by decreasing symptoms of claudication and elimination of the resting pain, and preserving limb viability and the prevention of amputation. Achievement of these targets requires the targets of treatment, or the principles of treatment, requires conservative therapeutic measurements involving risk factor modulation, antiplatelet therapy, using anticoagulation when appropriate, and using other pharmacotherapies that helps to relieve symptoms, and exercise rehabilitation. While the other modalities that are of help in improvement of quality of life and prevention of amputation is by the use of percutaneous therapy, which is using endovascular therapy, and surgical treatment using bypass grafting. The next category of the clinical presentation of patients with peripheral arterial disease is critical limb ischemia. The term critical limb ischemia refers to severe form of claudication, i.e. it's the end result of claudication, or even happens in acute limb ischemia, in which there will be a critical reduction in the blood supply, at which the organ affected will viability will be critically deranged, i.e. the limbs is threatened to be lost if this obstruction or reduction in the blood supply not relieved. Usually the patient suffers pain, paresthesia that worsens by elevation and improves by dependent position. There will be pallor, sometimes cyanosis, petechia, fissuring, ulcers, and gangrene, non-healing ulcers. The treatment of critical limb ischemia involves risk factor modulation, local wound care, and importantly revascularization. Amputation can be primarily decided when the tissue necrosis is extensive. Spinal cord stimulation and lumbar sympathectomy used to relieve cases that are beyond revascularization, and other investigative therapies like hyperbaric oxygen and therapeutic angiogenesis and the prostaglandins might be of help. While acute limb ischemia is a term implied to ischemia that developed acutely. احنا كل شيء that developed acutely، احنا كل term acute تقريبا نستخدمه when there is نطبقه على شيء على event that happens rapidly. Rapidly means that the affected organ would have no enough time to create compensatory mechanisms that helps to overcome this insult. بالنسبة لل peripheral vascular disease, acute limb ischemia نطلقها على occlusion in the arterial in the blood supply to an organ without leaving enough time for the collaterals to develop to compensate for this reduction in the blood supply. Therefore, the metabolic needs of the affected organ will outstrip the available perfusion, producing the limb viability at jeopardy. The clinical presentation for the arterial insufficiency is considered to be acute if it happens within 2 weeks after symptoms onset. The symptoms develop over periods of hours to days. The physical findings اللي نشوفها بالacute limb ischemia, there will be absent pulses, distal to the occlusion, there will be a cold limb, and that is followed by pallor, and then cyanosis and purplish mottling of the skin, followed by reduction in the nerve function and reduction in the sensation, and followed by loss of motor function, which is the which is a reflective of necrosis of the muscle. These features are often grouped into 5 P's, which involve pain, paresthesia, pallor, pulselessness, and paralysis. To the contrast of chronic limb ischemia, in which collateral blood vessels can compensate for the occluded artery, acute limb ischemia threatens the limb's viability because there is insufficient time for the new blood vessel growth to compensate for the loss of perfusion. Therefore, urgent recognition and prompt treatment and revascularization and relief of obstruction is required to preserve viability and prevent amputation. السلايدات اللي باقية اللي تخص اللي راح تشاهدوها وتطلعون عليها هي عبارة عن أمثلة أخرى ل non-atherosclerotic peripheral arterial disease. مثالين عليها هي Berger's disease اللي هو نسميه thromboangiitis obliterans، اللي هو smoking related inflammatory arthritis, and even affecting the venous side, and the Raynaud's disease or Raynaud's phenomena. تقدرون تطلعون عليهن بالكتاب، وطالعون الكتابة المكتوبة الموجودة بالسلايدات اللي تعتقد بها معلومات كافية. بنهاية المحاضرة أكو فد شيء لازم نعرفه، أنه patient with peripheral arterial disease is considered to be a high risk patient because of coexisting coronary artery disease that is present in around more than 2/3 of the cases of peripheral arterial disease.